Hey everyone, great to be here today. Thanks Rebecca for the intro. Merci à Gabrielle pour la traduction, to Fola and Robin and Alexandra for your back-end support as well, and everyone who's attending the event today. So I'll be moderating the discussion today. I'll briefly introduce myself before asking our panelists to introduce themselves. So my name is Liam. I've been involved in harm reduction for roughly the past 15 years or so in Montreal and Toronto mostly, where I've been involved in developing different harm reduction and overdose prevention outreach programs. And I've been involved in different drug user advocacy groups. So my entry point to some of this discussion today is as a community health worker. I was involved in the initial development during the first stages of the Safe Supply program at one of the community health centers operating Safe Supply programs here in Toronto. And in that role, I coordinated some community advisory groups and client advisory groups to kind of create a space to bring people who use drugs and prescribers and practitioners together to kind of share expertise and troubleshoot emerging issues. So yeah, and I'm currently doing research on drug policy and safe supply issues. So that's kind of where I enter this conversation. So yeah, I'll pass it along to our esteemed panelists. So let's start with you, Mish.
Hi, I'm Mish. I'm a nurse practitioner with the Parkdale Queen West Safer Opioid Supply Program, which is one of the SUAP-funded programs in Toronto. I have been doing safe supply prescribing for the last year and a half full-time.
And Mish, I forgot to say this, but could you tell us a little bit about what got you involved in safe supply prescribing?
Oh boy, what got me involved in safe supply prescribing? I as a teenager, grew up in a queer community, in a drug using community, and have always been interested in harm reduction. And when I became a nurse practitioner, I started to get closer to doing work with people who use drugs. And when this opportunity came up, I jumped for it.
Thanks. Thanks for that, Mish. Emmett, let's go on to you. If you could share where you work, live, practice, your role, and how you got involved in safe supply prescribing.
All right, my name's Emmett O'Reilly. I'm a nurse practitioner at South Riverdale Community Health Center, which is in the southeast part of downtown Toronto. I also live in the east end of Toronto. I started doing this work. It came fairly naturally out of my work. We've been doing harm reduction work for a long time, and then I did some clinical support of the unsanctioned OPS in the tents in Moss Park, where I first met Liam. And sort of once the CTS opened, South Riverdale has 2 CTSs attached to it, which for people who are outside of Toronto is a supervised injection site called communal consumption and treatment sites by our conservative government. So once that opened, I started hearing about safer supply from my director and from some other people, and it just seemed a very natural flow because we realized that the CTSs weren't getting the job done. So that's how I got into it. And did a lot of advocacy so we were advocating for this for about 4 years before we started doing it about 3 years ago. And then I've been doing it with pay for 2 years.
Thanks for that, Emmett. Sorry, there's some construction going on in my building right now. So Tracy, I'll pass it to you. Tracy, you're on mute.
Sorry about that. I'm joining you here today from the Katzie and Kwantlen territories here in British Columbia. So I started working in primary care with some marginalized folks up in northern British Columbia about 13 or 14 years ago. And I originally started doing a microelimination project for hepatitis C about 4 years ago at the needle exchange and OPS. And when I started doing that, I realized I couldn't actually do that without addressing like opioid use disorder, and that kind of evolved into a big a low barrier OAT clinic, and that kind of evolved into safer supply, and then now here we are today with all these tensions in safer supply and risk mitigation guidelines, and trying to address all of these issues and and kind of the barriers that we're seeing in doing that. So thanks for having me here today.
Thanks, Chrissy. Andrea, I'll pass it to you.
Hi, so I'm Andrea Sarita. I'm a physician at the London Intercommunity Health Centre in London, Ontario. Been doing Safe Supply for 6 years now, come this January. I can't believe it's been that long. And we have about 300 folks in London who are on the program. Thinking about kind of why we started, it was desperation. It was kind of, you know, a year or two into fentanyl being the predominant street opioid, and people were dying and we didn't have solutions. So our initial handful of patients was really just a last ditch effort to keep people alive, and now we're here.
Thanks so much for that, everyone. Can I just get a sense of how much you can hear me right now with this noise in the background? Should I? Okay, great. So it's maybe more. Okay, so yeah, we wanted to. Sorry, I'm getting some notes from the chat that people can't hear. So seems like maybe it's creating interference. So if we could just take a moment, I'm just going to ask Rebecca to do this section, and then I'll jump on in a moment. So Rebecca, I'm going to just email you this.
You know what? I don't have your Gmail in front of me or the Google Doc in front of me. I can hear you. You're just quiet. Let me just pull up your document that you're following through.
Let me know if this is any better. Apologies. Yeah.
I think so.
So I'll do my best and hope this dies down. Sorry, everyone. Okay, so we wanted to take a moment to set up the conversation a bit and how this panel came about. I think, needless to say, we're working in extremely dysfunctional systems, to put it lightly, and I think we can all agree that are failing people who use drugs in horrifying ways. So we're 5 to 8 years, depending on when you started counting, into this mass poisoning event that has taken the lives of over 23,000 people in just 5 years. And so just acknowledging that safe supply prescribing is just one among the responses to this crisis. So yeah, I mean, as you all know, safe supply prescribing is an emerging intervention. It's operating in the constraints of the health system, and right now specifically through mostly primary care and individual prescribers. So, I mean, many of us kind of occupy different locations within the response, either as professionals, as drugs, as advocates, impacted people. So everyone's grappling with this and working through these tensions in their work and in our lives in these different overlapping roles. So the hope today with the panel is really to name those tensions, name some of the dynamics that underlie them, just in a spirit of openness, and to be able to engage and critique and be reflexive also about our practices, not just as prescribers, but also as safe supply practitioners more generally, prescribing roles, recognizing the scale of the crisis and loss places enormous pressure on and the tools that we have. So just wanting to recognize that. So what are we talking about when we talk about tensions? I'd encourage everyone who hasn't had a chance already to check out the expert panel of people who use drugs perspective on safer supply that is on the NSSCoP site, which engages in a lot of the tensions we talk about today. So just to kind of name a few, you know, so safe supply prescribing straddles both medical and harm reduction worlds. At least kind of that's how I see it. And, you know, it takes up calls from movements of people who use drugs and, you know, tries to leverage the tools of the medical system. But recognizing that some of the tensions between, you know, harm reduction and the medical community are longstanding, right? But whether that's about, you know, whose knowledge is valued and why, whether it's around low barrier access versus kind of high threshold medicine, you know, consultation and the role of people in treatment decision making. So that being said, we've organized the panel into kind of 3 sections today. The first section is on safe supply prescribing and tensions between safe supply prescribing and kind of more traditional addictions medicine approaches. The second is on safe supply, between tensions between harm reduction approaches and medical community. And then third, more around tensions between safe supply prescribing and regulators, policymakers, health authorities. So the first section is on tensions between safe supply prescribing and addictions medicine. You know, I think safe supply prescribing departs from addictions medicine in a number of ways, right? Not looking at drug use necessarily as a disorder, you know, engaging people who use drugs in lines decision making and program planning, also in terms of practices around, you know, whether it's take-home doses, not placing prohibitions on injections, things like that. But these differences have also meant that safe supply prescribing has faced a lot of critique and vitriol in some cases from certain corners of traditional or more orthodox addiction medicine. So that being said, to set the stage, our first question to the group is, you know, what are some of the limits or shortcomings of traditional addictions medicine approaches that SOS is responding to or trying to address? You know, what hasn't been working for our clients, for your clients, with those traditional approaches that you've heard?
I think I'll take the lead on that one, Liam. So, you know, you're asking about kind of the comparison between safe supply and, you know, the problematic parts of addiction medicine. And I think it's really important that I think most safer supply prescribers, and certainly the people on the panel here, it's not just about the prescribing of the drugs, although that's obviously a huge, obvious part of it. But it's actually creating, you know, a culture within a clinic or within a program that's very horizontal, that's very non-hierarchical with our patients who use drugs, and really trying to treat everybody as equal humans with equal expertise and you know, equal experiences and listening to this, right? Because we acknowledge that safe supply actually didn't come from our brains of safe supply prescribers. It came from the community, and then we implemented their idea. So to really grow and stretch that idea, we need to keep listening. We need to be hand in hand with the folks that we're prescribing to. And so I think that's different than at least most of my experiences with addiction medicine, which again, from my perspective, my experience really aims to fix people, to make patients, you know, into a model of what the prescriber deems to be a good life. I think there's a lot of, you know, infantilizing behaviors like contingency management and so forth. And so we're really trying to step back from that and really express that our patients are, like I said, equal humans to us, and you know, should have equal autonomous decisions.
Thanks for that, Andrea. Does anyone else want to jump in with thoughts to that question? Kind of what are, you know, what were some of what did you see not working with addictions medicine in your practice or in your various roles in healthcare?
Yeah, I'll add on just to what Andrea ended with. I do think we try to have a really patient or client-led model. And at times, I will give people, I think, more options, or I often will give folks, you know, this is what the literature says. This is what sort of like the standard practice from the addictions medicine perspective. And this is what, you know, the literature says works or doesn't work. But acknowledging that there's also like tons of individual variation in responses to any approach in any area, and then empower them to be making the choices based on that information. So trying not to limit myself to different approaches. We're a bit more flexible that way.
Coming from, sorry.
Go ahead.
Coming from my practice, we had the biggest tension came from, you know, going with safer supply, the harm reduction model versus the medical model. The medical model in our community was very, like the philosophy was so different. The philosophy was very like abstinence based. So there was such a vast difference in between harm reduction with, I think, the safer supply prescribers. And then on the other end of the spectrum, we have the like abstinence based addiction medicine practitioners. So there was such this, great big divide between us. It caused so much tension that it was a very, very difficult place to practice. And that led to such, hostile and volatile environments. So it was very, very challenging, to practice there. But also, the worst than that to practice there was to be a patient there. So, keeping that in mind, it's very, very tricky. So to add that heaviness and responsibility to being a patient and trying to find a prescriber in this situation, and then going from one to another with, all these different rules, I can't imagine what it would be like to live that situation. Sorry, Emma, go ahead. I cut you off.
No, it's all good. I think the fundamental tension between what we do in SOS, Safer Supply, and traditional addictions medicine is just about trust. Like, I think the default position of the standard delivery model of traditional OAT is that drug users are to be distrusted. That's the default assumption until they have proven otherwise. And I think the position that we take is that we enter into a partnership, a trusting partnership with our clients, as much as we can. I mean, there are things that we have to do that look like distrust, and that's sort of fulfilling. That's more about that tension between us and our regulators. But I think for me, that's the fundamental difference. Is we start with trust, and build from there. And it can be a long time in convincing people of that, because I think we come with all the baggage of our fellow prescribers.
Thanks, Emmett. Why don't we briefly take comments from Mish and Andrea, and then I'll move on to the next question, which is related to this as well.
Oh, you're muted, Mish.
Of course I'm muted. I think another big difference is we acknowledge that the use of drugs plays a different role in different people's lives in different ways, and that not all drug use is pathological. Not all drug use is negative, and drug use serves a role for different people in different ways.
Mm-hmm. I was going to say almost the exact same thing, Mish. I think really centered in our program is the acknowledgement of the importance of euphoria in a human life, and not trying to implement, prescriptions or interventions that block that, right? That everybody deserves that, especially people who are having, a rougher time.
Thanks, everyone. So the timing's really impeccable. Every time I need to speak, the noise picks up again. So we'll try this. So maybe Emmett, you can kind of try to take the lead on this if you're game. But how should we be understanding the very public critiques of safer supply prescribing that we're seeing play out in a number of different forums right now? Can you kind of provide a bit of an overview of those critiques, right? Like thinking about newer prescribers or people who might be new to safe supply prescribing or on the fence, right? Like which aspects of those critiques, if any, should be engaged with, or how do we kind of engage with those things strategically? If you have thoughts on that.
Yeah, so there's a lot of critiques, but they sort of fall into some sort of broader categories. So there's kind of two questions here. There's what are the critiques, and there's how do we respond to them, and I think their function and the consequences of that. So our clients selling, sharing, compassionately assisting their loved ones with their medication. So medications that we are prescribing under somebody's name ending up in somebody else's, in a different person's body. We're doing some work around problematizing the concept of diversion, because it's just such a narrow and really judgmental term. So there's a lot of work being done through the community of practice around how to either resurrect the term or get rid of it, or what we're going to do. We're not sure yet. But so diversion and its consequences, both including overdose risk for other people and risk of enticing new users into using what are perceived as safer opiates. And this usually comes more from the public. There's this notion of facilitation that if you make it easier for people to take drugs, then more people will take drugs and they're not going to want to stop. Infectious complications is another big one that we keep getting from, this is one that is repeatedly shoved at us from the addictions medicine community, particularly on some of the forums, is this notion that because we allow injection in our programs, I saw in the chat that some people are in programs where they don't allow injection, but we do, that there's been a rise in infectious complications. There is, as far as we know, absolutely no evidence to support that. There has been an escalation in infectious complications related to fentanyl that sort of coincided with the increase of fentanyl in the drug supply, which makes a lot of sense because people are injecting far more frequently with fentanyl than they were with heroin, and each time you inject, you're running the risk of infectious complications. There was one very vocal person who gave some anecdotal evidence from their practice, and that's become a commonly referred to piece of evidence, which has sort of come back at us a lot. There is an article that came out of, or a research study that came out of France that links increased infectious complications with the injection of take-home pills. It's very important to note that that study specifically talked about sustained release medications and their injection risk. We don't provide sustained release medications for injection. So that would be like Acadian. And this is the reason why, and again, this is one of these tensions we're gonna talk about later. This is one of the reasons why we don't normally start off allowing people to do carries of Acadian, because there is such a big risk, and because this has become such a point of contention from that community, from the OAT community and other sort of anti-SOS people. I see Andrea has a question, has a comment.
No, I agree completely with everything you just said, Emmett. We keep getting you freezing a little bit, just so that you know.
Oh, sorry.
I really, and I'm going to run my mouth a little bit here, but I think it really boils down to every criticism that's coming out of the predominant addiction medicine community, to me, reflects them reacting to a loss of power and control over the field, reacting to a very different kind of intervention that's really being uptake by patients and is really, you know, showing the gaps and problematic things that are in addiction medicine. So almost all of the critiques, I think, are really from people's own loss of control.
Yeah, and I think that plays into the next part of the question, which is how do we respond? I think there is a risk in responding to people. So there's things to consider when responding to people. Is how much of an impact is their statement going to make? Like, is it worth responding to at all? Like, this is one of these comment section questions. Like, don't get involved in a troll fight in the comment section because no one cares and it's just going to piss you off. But there's a different issue when a prominent and well-known person publishes a 3-page massive spread in one of the highest distribution national papers in Canada that you kind of have to do something about and have to respond to. The issue is that when you respond, you start a fight, and everybody loves a fight. So sometimes getting the fight actually gives them more air and more press than they would otherwise want. So there's a tricky balance there in responding. We have done, I mean, Andrea, more than any of us, have done a lot of toe-to-toe with people in the listservs and chats and forums that pop up. And I think those areas are very different because those are kind of hidden from the public. So I think we have to be careful when we get into mudslinging or what can be seen as defensive responses in public. But in sort of more sheltered forums, like places that are only for providers or people with vested interests in addictions, then I think, you know, the responses can be very different. Andrea, or is your hand still up?
Yes, I put it back up. Sorry.
Okay.
I've lost. I think I'm just excited to talk about something other than Omicron today. So, like, thank you. No, I agree with Emmett. I think early on in, you know, these public criticisms of safer supply, we tried to respond with education. We tried to have very reasonable approaches to it. got us nowhere. They didn't want to hear it. And they just repeat the same criticisms over and over again publicly. So my grandmother tells me, if you wrestle with pigs, you're both going to get dirty and the pig will like it. So I think that's almost our new approach, is that we only will engage in valid criticisms, and the invalid ones really are not worth our response.
Yeah, and I think there's also something, we've entered a new phase, I think, in safer supply. Like, we're not the kids in the corner anymore. We're actually kind of out in front of it now. And I think, you know, we're getting federal funding, we're getting recognition, we're being cited and referred to, and so on. So I think, like, the trying to fight for our little piece of real estate is no longer the fight. The fight is now for stability. The fight is now for real funding and long-term funding. So I think, like Andrea said, I mean, we had a similar thing in the Emerge, like, never argue with an idiot. They'll bring you down to their level and beat you with experience. So just don't engage. And I think that we're in a position now where we don't have to fight every fight. We can just ignore people now sometimes.
Thanks for that, everyone. I'm seeing some comments in the chat from Tara and Julia, just around, I think around like high dose and injectable formulations. And it really strikes me that the kind of issues that we're dealing with in, say, supply prescribing, particularly in Ontario, but not only, right? You know, is limited not by problems inherent to the approach, but really by a poverty of options, right? Like, we're working in the Ontario context only with, you know, D8s really, as well as other options, right? But just underscoring that the regulatory side of it and the formulary side of it, right? And the advocacy that needs to happen in terms of the Ontario drug benefits, and of course in other provinces as well, what's on the public formularies. I wanted to move into the second section, which is really kind of more around that piece of accountability, tensions between harm reduction and the medical community, and the kind of like legacy of you know, medical neglect, medical violence that in some ways all of you as practitioners, as prescribers, have kind of inherited and are negotiating in your clinical practice, right? And are negotiating in terms of relationships and trying to rebuild that trust, both with individuals, right, but also at a community level. So, you know, I think those tensions play out really explicitly when it comes to, sorry, just dog had a spill there, apologies. Lots going on over here. So yeah, I mean, that plays out obviously at the individual level, but then also plays out at a much more systemic level, right? And that's gonna, of course, be particularly felt among, you know, Indigenous and racialized drug users, mothers, parents who use drugs. So at the same time, there, you know, been demands, sustained demands from impacted communities on healthcare institutions, right? To step up and play a more substantial role in developing solutions to the overdose crisis. So yeah, this section is really about how do you negotiate that in the day-to-day. So the first question we had is really around accountability. I mean, I think it's all you guys have spoken to already, right? The moral or ethical accountability you clearly have to people who use drugs and the communities you serve is kind of shown in your advocacy around safe supply prescribing and how you come to it. At the same time, you are constrained by your role or position, perhaps in certain ways, right? Around like being legally or professionally or you know, contractually accountable to like professional associations, colleges, things like this. So, you know, do you see those accountabilities as in conflict with one another? I know that like people who are kind of on the fence have struggled with this. You know, am I kind of framing it as a bit of a zero-sum game? Is it possible to reconcile them? How does that play out in the kind of day-to-day? Whoever wants to take the lead on that. I have you down, Emmett, but it could be anyone else, so no pressure.
I'm happy to start it.
Sure.
Yeah, I mean, I think there are definitely points of conflict between, because we're trying to use a tool, healthcare, that was not designed for this purpose, right? This is a problem that's generated by crappy public policy and racist and colonialist public policy. It's a public health issue that's being tackled by individual providers. So it doesn't doesn't fit. And so sometimes when you're using the wrong tool, like the mismatch is going to become evident at some point. I think there are ways to navigate it. I know all of us were frightened when we started doing this work that, you know, our licenses would be in jeopardy. I feel like that feeling has passed. Like especially because we have such a robust community now, for any regulator to come after any single one of us for practicing reasonably in consultation with a large community is going to be hard. You know, there are other liabilities. There are like civil liabilities. We could be sued by a family if they die, somebody died from an overdose, things like that. So that is not a huge concern for me, but every once in a while when I can't find a patient and I'm worried about them, the thought does come to mind. I think ultimately you know, some of the issues that we're asked, some of the things we're asked to do by our regulators, such as like, you know, do things like have mechanisms in place to monitor for diversion, I think are reasonable, and I think unfortunately they're tools that have been used by traditional modalities to reinforce that distrust and to use them as weapons to try and make people, to try and control people and try and reduce the risk to the prescriber. And I think, you know, it takes some time. Like we use things like UDS. I've had some really beautiful conversations with people when they find out what's in their urine when it comes back from the drug use. Like they think, you know, I'm getting fent, and I'm like, well, you're yes, plus this, and this, and they're just shocked. And it can be a great moment for people. So I do think the tension is that some of us are able to find ways to prescribe within those restrictions fairly safely. Oh no, I think I've lost my connection. Sorry, I'm gonna turn my screen off, see if that helps. No?
We can still hear you.
Oh, okay, good. Sorry, everybody else froze on my screen. I'm actually gonna let Mish talk because I seem to be in a bad spot in the universe right now.
I just wanted to add, I do feel this tension though, you know, even though it has improved, because I often say to new prescribers, you know, like we are a federally funded program at this point. I think there is less of a chance of being, you know, brought to a college when this is obviously pretty sanctioned, at least in the way that we're practicing it now. But we do really want to be so responsive to lived experience, to knowledge that's generated from the community. And I find that does still often butt up against expectations from the college, from regulators. I see this in places like titration. I often feel like people have been able to self-titrate their own substances for years quite safely, but I do still need to start at these really low doses and go slow in ways that I don't think is serving clients the best that we could, but I still feel like I have to take a really cautious approach because of those regulators, because if anything happened, I could be held accountable. And that's one of the ways that the medical model doesn't serve people very well, because people could be doing this a lot faster and better for themselves if there was other ways of access. Often I really feel the need to protect the programs, and sometimes that's why I'm doing things in ways that aren't as client-centered as I would want it to be, because I feel like, oh, if the program's audited, if I'm audited, and you know a regulator feels in disagreement with the way I'm practicing, you know, the whole program can be at risk, and safe supply prescribing in general could be at risk. So that's a huge tension for me.
Thanks for that, Mish. I guess kind of just to expand on that question, is related to that, you know, you're talking about where patient-centered care rubs up against the kind of obligations to follow guidelines within a reasonable rate, and the kind of regulatory and constraints that you're dealing with. So where do we go from here, right? So, you know, I'm thinking about like, where does safe supply prescribing need to move in terms of, you know, centering clients in clinical practice, but also at a program level, you know, and taking direction from communities of people who use drugs, which obviously Safe Supply has done since its inception. But how do we kind of structure those things in, right, to ensure that the broader environment of hostility and critique isn't creating a dampening effect on kind of clinical decision making or on program practices? So I don't know if anyone wants to address that. Yeah, Tracy, please.
Oh, okay, good. I think so perhaps like broadening the prescribing base up, maybe that would be part of it. Right now, it's very narrow for physicians and nurse practitioners, except in BC, we've now opened the scope up for RN and RPN prescribing for OAT and Safe Supply. Like the Provincial Health Office came out with in September that for RN and RPN prescribing. So that's been taking place now. The BC-CSU, Ministry of Health and Ministry of Mental Health and Addictions came up with this policy, and BC-CSU has developed the education. So RNs and RPNs have gone through Suboxone, methadone, and SROM education, and Safe Supply is coming. So I think that's a really good start to opening the doors for like a more balanced place for patients to be able to at least start and get on some opioid replacement therapy. And Safe Supply should be coming along shortly. So that's one avenue. I think people will be able to get more options. And I think we have to move along with pharmacists too, to be able to do the same things, but at least in the beginning to extend and prolong prescriptions, because that's, I mean, they do it for Ramipril and metformin. I don't understand why this is any different. Like, because right now, if you miss 2 days of Cadian or 3 days of methadone, you're cut off, or whatever they do with Safe Supply. Some of them decide they're going to cut them off, and some of them they don't. So I think there needs to be more leeway and more clarity and directives about what pharmacists can do as well, because I can tell you that the pharmacists that I usually work with in the community, there's really some excellent ones that will just continue on patients or phone me or throw me a text on the weekend, and like the continuity of care is really fantastic. So I think if we had more engagement with other and alternate prescribers aside from just the like the addiction medicine physicians or addiction medicine prescribers, I guess. I think that would be a really excellent way to go. And then I think there also needs to be other models as well. Like we have the First Nations Health Authority in BC that does a lot of virtual care. And I think that they are reaching a lot of places that they didn't think they were going to reach before. They thought they were just maybe going to go to the like rural and remote areas, but I think that they're even like doing urban and central areas as well. Like people are able to just call or like virtually, they got like virtual or telephone. So I think that's really excellent. And I think probably what everyone is thinking when they're listening to me now is like, well, what about like co-op models or the compassionate clubs? And I think, yes, but like I can't, there's other people that know about that can work on that. Like I can't do that right now because I can only do like the prescribed model. That's all I have the capacity for in my own time, in my own mind. And that's what I can do. So going back to the prescribed model, and I guess the medical model, when I see that too, the biggest problems and tensions I see with that are what you spoke to earlier. Like, why is it so medicalized? Like, why aren't there more carries? Like, for someone to pick up methadone every day, like, oh my God, that drives me crazy. When COVID first came out, for example, they were doing month-long carries of methadone, and they had a program in India, and no one died. Everyone was happy. Like, that was just fine. I don't understand that. And currently now we have like supervised fentanyl distributions for like Fentora and Sufentanil and those kinds of things. And so that's not really Safe Supply, is it? Like if you have to go and be witnessed every day to take those medications, the only ones that are kind of Safe Supply are the Dilaudid or MS-1 that they go to the pharmacy, but it's still every day. Like like you have to go every day to the pharmacy. I mean, I know I have patients that go and they pick up a couple of 8 balls on a Monday, and like they divide it up in the week, you know, because they're going out like wherever they're going to go, if they're going to go fishing or if they're going to go to work or whatever they're going to do. So I am sure that they could manage to pick up whatever their prescribed safe supply is and use it just as, you know, liberally as they want to during the week. Anyway, that's what I'll say. I see other hands up. Sorry for now.
I completely agree, Tracy. I think we're all trying to work towards demedicalizing this as much as we can, right? With you know, still having to work within that. I think when we're talking about capacity versus community need, I think the elephant in the room is this is probably never going to be solved by prescribers. There just are not enough of us, and we just cannot see enough people. I've been doing this for 6 years. I do it 5 days a week, 7 days a week, and I have 300 people, and I cannot see any more. And that is a drop in the bucket, even in London, Ontario, which is a mid-sized city. So, you know, we're advocating, we're growing the community of practice, we're getting more prescribers on board, but I just cannot imagine a reality where we have enough prescribers for everyone who needs this. And so really, you know, my thinking even in the past year is how do we pivot? How do we use our experience and our evidence to start pushing for legalization and regulation? Because that is the only way we're actually going to really address the entire community need.
Yeah, I think this is one of the ways I try and look at safe supply and like this timeline of gradual decriminalization. And it's sort of what harm reduction has been doing all along, has been taking little bites out of the criminalization of drug users and drug use. You know, we did it when we, you know, needle exchanges were the first little bit, well, okay, you can carry needles, but if you want new ones, you got to bring back old ones. And then it was like, well, that's dumb. Let's just give people needles whenever they need them. Okay, but that's not enough. Let's let them use inside in this, like, you know, my building has a little decriminalized 2 or 3 rooms in it. And that's really cool to me. Like there's a space downstairs that is a bubble of decriminalization in Canada. And now we're doing a little bit more of it here. And, you know, like this is one of the few sort of hopeful parts I have is that, you know, Toronto's Board of Health just put in a request to have personal use of all drugs decriminalized within the city. And I know Vancouver did the same thing. Like that's huge to me. Like I've presented to the Board of Health a dozen times. They're not raging progressives. They're not ready to change the world, but here they are asking for something. So like, I think we are making these little moves towards decrim. And I think this is a small, insufficient, frustrating little part of that movement.
But we need to fill the gap until then.
Yeah, so if I could, thanks for that, everyone. This is great. So I guess I'm wondering, how do we, you know, you guys spoke to a number of issues, right? Around expanding the prescriber base, around recognizing that prescribing and medical models alone are not going to get us out of this, and need to kind of support a broader kind of coalitional, you know, diversity of tactics kind of approach to this. So in the kind of short, medium term, I suppose kind of a follow-up question I have for all of you is, how do we work towards broadening, expanding access in the ways that you've talked about, while also dealing in the short term with managing demand on programs? So how do we not kind of institutionalize or lock in higher barrier access criteria? Because I think from where I sit, yeah, and this is coming more from a community health worker perspective and not a clinical or prescriber perspective, is that, you know, we're dealing with very real constraints and very real critiques that inevitably have a bearing or an impact on people's clinical practice and decision-making and whatnot. So how do we, yeah, what is there anything we can do to kind of safeguard against that, like high threshold access getting locked in, if you know what I mean, right? I'm thinking about like a lot of the IO programs in BC were kind of sold as, you know, this is for extreme cases, or, you know, you have to meet these extremely high risk thresholds in order to gain access. So is there something we can do regarding that? I don't know if that question was clear. We kind of merged into a few questions here, but yeah, Mish, why don't you start us off?
Yeah, I think you know, we really strive to be low barrier, but I think all of us acknowledge that in this medical model, there are high barriers. This is a high barrier way of delivering safe supply. It involves appointments, it involves phone calls, it involves so many things that are just they're difficult. I think lost my train of thought. I think we need to be advocates for our clients at all turns, and be advocating for different models that are lower barrier, and keep pushing ourselves in our practice, and involving the voices of people who use drugs, whether that's directly from our clients, whether that's from community critique or from advisory committees, because they have the knowledge that we need in order to make this more accessible. So it's definitely an ongoing problem. And for me, I do think that anyone who is using an illicit supply deserves access to a safe supply. But at this point, because there's so few of us, there's so few prescribers, and there's such little funding, we do have to put in place these criteria to try and make sure that we are getting people who really desperately need access to it. But it's very ethically complicated, because we often see folks that we know would benefit from the care that we provide, but there's just such big limits to what we have available.
Yeah, Andrea, do you want to?
Yeah. If I pipe up, Mish actually said almost exactly what I was going to say, right? That I'm hearing Liam say, and I can see it in the chat as well, that currently we have these, you know, criteria that say you have to be so sick, you have to have all these overdoses, you have to have HIV, you know, not even just HIV, untreated HIV, to be able to get in. And it's just a direct reflection on capacity, right? And we've had to make these decisions about who's going to die first. And unfortunately, often we're not right. And I think we all have the experience of people dying on our waiting list. And I think it breaks us all the same. Before, you know, in London, before we really hit our capacity, we tried to do a mix of, you know, higher need and, you know, lower need. And it was really amazing to watch people who, you know, were still housed, still had family engaged, still had a, you know, just stabilized with like 3 or 4 weeks of safe supply, that everything just came back together for them. And they felt like such slam dunk easy wins. And I think we all wish that we could offer that so broadly, right? It's just too few people and too much need.
Maybe some brief remarks from Tracy and then Emmett before we move on to the next question.
Sure. I just it's basically along the same lines, like the high barrier approaches with the daily eye out. It's for a very few people, a very marginalized group of people, you know, and who we see have the highest stats of dying between 29 and 59 are men working in the trades. And we don't even know if they've been diagnosed with an opioid use disorder or substance use. And they're the ones that probably aren't even engaged in care. So like, how do we reach that group? Because I don't even think that they're engaged in care, and those are the people that need the safe supply. So that's a big problem. That's a big tension of mine.
Yeah, I think there's two things. One, I think there's place for some of the maybe not lower barrier, or maybe not higher barrier, but less supportive programs for treating people who are less in need than some of the people we're seeing in our programs. Like I'm thinking of RAM clinics and things like this, who aren't going to offer wraparound services, but not everybody needs wraparound services. You know, like some of the people that Andrea was talking about, like they just need the supply. Like, just give me my script and I'm going to go, and I'll see you in a week or 2 weeks or whatever it needs to be, and they can function without the level of support that we give. And I think we need to allow space for that and try to avoid sort of demonizing people who are not comfortable doing the work we're doing, but are comfortable doing that level of work. right? Because I think that that's an important contribution for some of the people that Tracy talked about and some of the people that Andrea talked about. And I think, so the second thing I would say is that we need to, in order to stop that from becoming the norm, we need to speak when we have the chance. Like speaking at forums like this is nerve-wracking for a number of reasons, but you know, we also need to, like, when the health minister showed up at my community health center and said, we're giving you funding, we said, thank you. Every single one of us said, thank you very much, but, right? And then we spent most of our time after the but. So we need to continue doing that. Like, thank you for funding Safer Supply, but just so you know, we realize you're doing this so you don't have to decriminalize. We still see you putting Indigenous people in jail. We still see you putting Black people in jail. We still see you hurting our clients and leading them down the road to death. Thank you, but we're still watching you. You're still going to get emails from us. You're still going to hear, and like, because we get invited to tables that our community won't, and so we have to bring their voice there as much as we can, and continue to talk about barriers.
Thanks so much. I think all of you, are speaking really powerfully to the kind of, not just like the ethical and moral burdens that we're all negotiating, or, you know, particularly people in your role, but the risks involved if we get used to this kind of extreme triage that really undermines universal access and undermines the right to health. So keeping our eye on that and not normalizing that, I think you all spoke to that really powerfully.
I'd also just like to say that that leads to a lot of burnout from clinicians, because people that do this work are people that want to say yes to everything that our clients come to us with, and when we have to say no, it's heartbreaking.
Before we close on this section, I was just wondering if we could maybe speak briefly to, I mean, Tracy, you spoke earlier to a lot of the really important advocacy that's happening within the medical community, right? In terms of people in different sectors, in RAM clinics, Emmett, you were talking about that, and kind of more collaborative approach. I guess I'm wondering, I guess the question I have now, and this is kind of question 6 more or less, although we've touched on it, but is around the meaningful engagement of people who use drugs more generally, around how we live and practice nothing about us without us as a kind of organizing principle in our work. And, you know, I think 90% of clinicians you speak to would say that they practice client-centered care, right? But that is going to look very different to different people. And, you know, the experience of that on the patient and our client end is obviously going to be really different. So the question I have is, how do we move beyond token inclusion? I'm thinking a little bit here about some of the client and community advisory groups that were really kind of undermined with COVID, right? That created a lot of issues around kind of removing that platform or putting a lot of barriers in place in terms of that platform as a space of kind of convergence, or as a space of, you know, accountability and dialogue. So, I mean, that's just one example among, you know, a number of potential examples, but I'm wondering if you guys have thoughts on that, you know, where does meaningful engagement fit into this beyond maybe this is more of a program question, maybe this is more of a question for program coordinators and community health workers as well, but yeah, any thoughts on that would be appreciated.
More engagement we have, the better. I mean, COVID has really killed our ability to do the community advisory boards that we were hoping to do. But more than that, I think what it's really killed is our ability to provide a space for community to grow. When we designed our program, we designed it around our Hep C, our community Hep C treatment group, which was a group. And the Hep C treatment was an and also. So people came to the group and they built community, and they learned things and they shared things, and then we also did Hep C care, right? Like, we also provided medications and treatment. And that was our hope with this, was that we would be able to have days where people could come together and have community, food and educational resources and empowerment stuff, and whatever the hell people wanted. Like, you want to do macrame, fuck, do macrame. So that community, I think, also is needed to have a good, like, patient advisory board. You need that community to be feeding the patient advisory board, which tells us what we should and shouldn't do. So I think we've lost both of those things because of COVID. And like things were looking really hopeful until about 2 weeks ago that in January we'd be able to open things up, but back we go under our rocks.
Thanks, Emmett. That's great. This is a really, this is a great conversation, everyone. So we wanted to move into, in the interest of time, the third section. So maybe we'll take 10 minutes or so to deal with this, and I'm hoping to maybe spend 5 minutes going over kind of question 7, which is really around how prescribers are being positioned as the solution by certain persons, right, in the absence of maybe other structural interventions, and then take 5 minutes to kind of the issue of diversion or non-medical use, or however we want to frame it, which was brought up at the beginning of this. So, you know, I think it's, you know, we spoke earlier, all of you spoke earlier to the constrained policy environment that you're working in terms of colleges, in terms of the gray areas around off-label prescribing, in terms of, you know, diacetylmorphine and higher dose formulations not being available in many provinces. So, I mean, this policy setting doesn't just create risks for you as prescribers, but obviously it creates specific risks for clients, right, and patients. And so, yeah, the question I wanted to ask next is, you know, are related to prescribers being used or positioned by health authorities as kind of the solution to the overdose crisis. And this has kind of raised concerns among some more traditional addictions medicine doctors who are kind of reluctant to embrace safe supply prescribing, or might claim that this is the reason for their reluctance, for instance. But it's also, you know, being raised as a concern by safe supply advocates concerned with, you know, government's response to this crisis, and it beginning and ending with the prescriber model. So, I mean, we've touched on this a little bit, but I'm wondering, how do you respond, you know, to clinicians and prescribers who name that as a source of their reluctance to come on board, and how do we position ourselves in our advocacy to make sure that this doesn't end and begin with the prescriber model?
Yeah, I think that that is a sincere fear for myself. I think I've learned more about politics in the past 5 or 6 years than the rest of my life combined. And I echo what Emmett was saying earlier, that when we got this funding, we said a big thank you so much, and we also need this. And I think we were still hopeful, but we also need this, what would start to emerge. And I think it really hit home to me in the last federal election, when on, you know, the Government of Canada website, under solutions to the opioid crisis, they listed the programs that they have funded as if that's a solution. And I found that really disheartening. I felt like a tool in the government machine when I saw that on the website, because this is only one small part, and they've only funded tiny programs across the country. So we do need to keep pushing back that this is not the be all and end all. This is the very starting point of, you know, what is probably a marathon race, and we need to keep pushing the government on that. In terms of, you know, our addiction medicine colleagues who, you know, are saying, this is being presented as the solution, so I'm not going to do it, or this is a small funded program. I call bullshit on that. You're not going to do it anyway. They're just looking for an excuse. Every single prescriber that we bring on board, whether they do 1 patient, 5 patients, 10 patients, 300 patients, is adding to the solution. So whether this is whatever the government is saying about it, make your own individual choices to do the right thing.
Tracy, do you want to take it from here, and then we'll take comments? Oh, mute.
You would think I would learn after all this time. So I was working in a health authority in a clinic, and doing my own prescribing, and running into a lot of roadblocks with this. And then I started working for the government in the Ministry of Mental Health and Addictions in BC. Because I thought, maybe if I go at this at a different angle, it will be the solution. And I will tell you that the people that I work with in this ministry, they are all of the same mind as us sitting here today. They are an extremely brilliant, bright group, like working for all of this policy to go forward and be forward thinking and progressive. And I will tell you that it is like hitting a brick wall. It does not trickle down. It gets diluted until you don't even recognize it. So it is like maybe other parts of the government, I don't know, but where I am currently seated, I don't know, where I currently am, it is like a really great place, but there is no flow. Like it doesn't work. There is brick walls through the health authorities. There is like all of their bureaucracy is where it does not flow. So whatever happens there, it's a mystery to me. But from the plan and the ideas and the money to like on the ground working, there is like a void, a black hole. I'm not sure, but to be on the ground and working with the patients, we don't see that space in the middle. There's a big blockage.
Thanks, Tracy. Mish, do you want to add to that?
Often I've heard this phrase, and I think it came up in some of the recent criticism about, we can't prescribe our way out of a crisis. And I don't think any of us think that we can. I think a lot of the hopes is maybe we can keep people alive long enough for all of the other social changes to happen that can more address a crisis. And I think we especially know that when we know, at least in Ontario, the medications that we have, just having Dilaudid is definitely not enough. It doesn't even quite meet the criteria of safe supply for a lot of folks because they're not getting a euphoric effect. So a lot of the benefit that I see in the programs also is just our approach to people, and our approach to care, and how much that itself is changing lives, is helping people access care that they need. And whether people are going to be prescribing safe supply or not, whether they agree with that approach, I think all of that can also be taken from this, that people need to change the way that they're practicing in order to engage with people, treat them with dignity, and really advocate for people within this system. And that's something that can still be learned no matter what you're practicing.
Thanks, Mish. Wanted to take a few minutes just to talk about diversion, or what we frame as diversion currently. We touched on this a little bit earlier. I think it's safe to say that perspectives on diversion, or just sharing medication, whether that's with a loved one or partner who's dealing with withdrawal, whether that's for income, perspectives on that vary by clinician. So on the one hand, there's this kind of recognition and some emerging evidence, right, around the kind of potential for a broader protective effect in terms of diversion, right, in terms of moving other people who aren't in the safe supply programs, away from a contaminated street supply. But you also spoke earlier to how diversion presents clear kind of reputational risks, if we want to call them that, for SOS prescribing programs, and how this issue, even though, when Tracy, when we were chatting the other day in prep for this, you were talking about there's, a diversion market for Ensure and meal supplements, right? We divert our whatever's in our pharmacy cabinet to friends and this time, right? And so, but somehow there's a kind of exceptionalism in terms of how we talk about diversion in this frame. I mean, this is kind of where I'm coming at it from, but recognizing that diversion can be used to kind of create a boogeyman out of safe supply prescribing. And I'm just wondering, how do we engage with this? You spoke a little bit earlier to that on the, on a clinical practice level, right? But how do we build, how do we need to talk about this publicly? How do we engage with this strategically? If you have thoughts on that before we open it up to broader questions.
Show me the evidence. Like, show me the evidence. I have all the clinical stories. I have like borrowed someone else's prednisone when I needed it. There's street value, like I said, for Ensure. I would like for someone to show me the evidence, and then I will believe it if it's high enough quality. that's all I have to say about that. I don't know if anyone else has something better.
Yeah, Mish, feel free to jump in.
I think some of the concerns that are expressed around diversion come from this assumption that like the existence of available drugs is what leads to harm. And I think all of us can see and recognize that there's way more causes for problematic substance use. You know, fentanyl is there, it's on the street. I could go buy it, you could go buy it, anyone can go buy it. But there are reasons for why people use. And it's not the availability of a substance that ends in harm. So I think the whole framing of the question about diversion is sort of a distraction from what the root causes of harm are in our society. You know, why are they so focused on diversion as the cause of harm? And we're not talking about criminalization. We're not talking about people being incarcerated. We're not talking about poverty. We're not talking about all of these things because those are a much, much bigger cause of harm.
Yeah, Emmett, feel free to jump in.
Sorry, I think my screen froze. So I think there's sort of two sides to diversion. Like I think I totally agree completely with what everyone said. I think some of the fear about diversion stems from like this 1980s Nancy Reagan fear that how people are diverting is they're waiting around the corner for your kid to come skipping down the street and then accost them and like force them to take these drugs or pressure them. Like this is the notion that I think the public has of drug users, that there's like this predatory thing that's going on and they want to like hook everybody, or they're somehow going to get everybody hooked on drugs. So I think that's part of the fear that comes from well-meaning people. I think there is a lot of cynical crap going on in the addictions medicine community, and I would agree with Tracy that they need to show us the problem, and the onus is on them for that. I think as a prescriber though, diversion is tricky because it's like, how do I know what's working and what's not working if I don't know what people are taking? Right. So if I give you 24 tabs of Dilaudid and you tell me you need more, but I have good reason to believe, or I'm suspicious, or there's a concern that you're diverting, then what am I doing with that more? Or am I helping you? Is your tolerance really super high? Is what I'm doing working? So this is part of how diversion sort of affects our ability to prescribe. That is clearly a secondary issue to people taking care of their loved ones and so on. But it's definitely a complicating factor. Like it's not I think sometimes our community can be a little dismissive of the concerns around diversion by saying that there is a broader public health benefit. And I totally agree there is. And I think that on the scale, that is far better than the downsides of diversion. But I think diversion is not a completely innocuous thing in all of its forms.
Thanks, Emmett. Tracy, do you want to close us off and then we'll open it up to Q&A?
Sure. Just in a brief response to Emmett, I think the only way to address that is in the relationships that we develop with our patients, in asking like, why do you need more, or why is there no hydromorphone in your urine this time? Like what's happening, like who's taking it, or like what's going on? And for the most part, I have relationships that are really long lasting and strong with my patients. Some of them not so much, but most of them I can ask and they'll tell me like, oh, you know, my boyfriend took it, or my grandmother, I either have to give it to my grandmother or I have to go sell my ass and then I have to get drugs for her. And then so it's actually still safe supply, because like it's still safer to give her the Dilaudid than it is to have her sell her ass for, you know, put her in that risk situation. So if I'm able to have these conversations, we can still suss it out. And then, you know, I can ask her to bring her grandmother in and we can like put her on, you know, whatever medication that she needs to be on. So I think a lot of it is probably what we all do here is try to develop like therapeutic and reciprocal relationships with our patients, so that there's this understanding that if you just tell me what's going on, then we're gonna just fix it, or fix it as best we can, so that we're meeting the needs of everyone that's involved.
I think this is where we come into one of the problems with like our limited capacity. Like I would love to just say, you know, oh, that person who you needed to give your D8s to, can you just bring them in and I'll give them their own D8s? But I can't. So yeah, like if we had a broader community and more resources, we could for sure do that. Agree with everything you said. Yeah.
Thanks, everyone. Awesome conversation. Really appreciate everything you've shared, and the kind of, just grappling with these issues and the reflexivity and kind of openness to dialogue you've all shown. Just a quick plug that this is put in the chat, but there is a poll survey to fill out. So if everyone could take a moment after this webinar ends, but we'll spend the last 15 minutes or so, or however long we have, getting into Q&A. So I'll start with this one. Seems to me that NPs have been more willing to take up safer supply as a treatment option for their clients. I'm curious to hear if panelists have a perspective on this, if there are thoughts about what might underlie this difference in terms of training, professional practice, culture, policy. Add to that potentially regulator differences. Who'd like to start us off with that?
I can speak to that a bit. I think part of it is just the structure of the funding, that NPs got involved, and also NPs are also working in other places within our city where safe supply is needed, like in the COVID shelter programs, for example. But I do think that we also come from a unique perspective and have often been embedded in community health settings, have often been really invested in social determinants of health. And I do think our approach is sometimes more personable. I think we're used to giving a sort of personalized approach at bedside in the hospital, for example, and are often helping people navigate through the healthcare system. We all have experience as RNs doing that with our clients. So I think there are some additional skills that come from having been a bedside RN that do add to our abilities.
I think we also, as nurses, we have a different history with opiates. Like I think the medical community specific. So when I say it in that context, I mean physicians. They went through the overprescribing and the deprescribing, and there's a lot of history there that we don't have as NPs. We're all new to this. We didn't fuck it up. So I think that's helpful in a lot of ways. And I agree with Mish about the very personal approach. Like I think harm reduction fits very well with how nursing approaches client care. We're not as risk averse because we don't get sued as much. So I think that helps.
Just to add, I think many physicians do also carry these skills and traits. I think there is some that's just a little bit more integrated into our education at points.
And I just want to say, Emmett, you just totally jinxed yourself getting sued tomorrow, but we'll work through it.
Well, that's something.
So the next question we have here is, has anyone faced tensions between themselves as a safer supply prescriber and local drug dealers whose business may be impacted by the safer supply program? So dynamics around, lowering value of D8s potentially as availability increases, or related issues to that. Yeah, everyone's shaking their heads.
I would say my local drug dealers have enough work to go around. I think we're such small fry even in London, city of 400,000 people, right? We're such a tiny drop in the bucket of drug use in town.
I think the tension that we've come up to is some local drug dealers have been pressuring people to sell or give over their supply. This is one of the challenges with people knowing who's on and who's not on the program, is people can be victimized for the drugs. People have been jumped right around the corner from the pharmacy, so people see, oh, you're going to the pharmacy, I know what you're getting. You're gonna have a full container of Dilaudids coming out. So there have been some interesting things around our center recently about sort of some drug dealers it's hard to describe. I'm not sure the source of it, but it does seem to be related in some way to safe supply, but more about taking people's safe supply than being particularly upset with us as competitive dealers.
Mhm.
I've gotten more negative comments from the addiction medicine physicians in my community saying that I was causing drug tourism by prescribing safe supply.
Oh, the famous honeypot argument, right? That we've dealt with for what, about 30 years now around, you know, needle exchange, needle syringe programs, safe injection sites. We're all supposed to create this honeypot effect. It's interesting to see that one rear its ugly head once again. Just moving on to the next question. In addition to concerns about loss of power, do you think part of the tension from traditional addictions medicine comes from fundamentally different ideas about the nature of addiction as patients' pathological loss of autonomy over substance use and a professional sense of identity or ego based on working so hard to protect people, in air quotes, from prescription opioids? In some ways, addiction medicine is more progressive than other parts of mainstream medicine, but in other ways, it's far more carceral. So that's in the chat if anyone wants to reread that. But if anyone has thoughts on that comment, please jump in.
I think the answer is yes.
Yes.
Hi, yes. It really, it is very much screaming systemic racism in the healthcare system. This is a perfect example of it right here in that comment.
And my experience, and there's lots of wonderful addiction medicine providers, but my experience is that all drug use is seen as a problem to be fixed. I really haven't, bumped up against an addiction medicine practice that doesn't have that as their bedrock assumption. So yes, absolutely fundamental different ideas where we actually believe drug use can be an integral part of somebody's life, and we want to make it safer.
Yeah, and I think underlying that, I mean, you guys have spoke to this earlier as well, right? Andrea, you were talking about the kind of prohibitions on pleasure and on euphoria that have created the bedrock of addictions medicine in many ways. And underlying that is, of course, who has the right to have pleasure and who doesn't. I think another point that you guys have touched on is also the very different evidence thresholds that we're working with, right? Where does whose knowledge is valued and why, right? So Mish, were you going to jump in with thoughts on that piece before I move on to the next question?
Yeah, I think the part about pathologizing is also really important, that if you're seen to have a substance use disorder, that you're immediately distrusted in our system. And I often, when I leave a pharmacy with 3 months worth of narcotics prescribed to me, I often think, why do they trust me to be able to walk away with this, and they don't trust so many other people? And to go from a place of mistrust and then slowly increase it to being trustful is just the opposite of what we do in other areas of care. And why is that our default?
Thanks, Mish. So yeah, let's maybe do one or two other questions before before I pass it back to Rebecca to close us off. So next question is, are there any local efforts to better coordinate efforts between OAT, other more traditional addiction medicine, and safer supply programs? How does that work? Is there kind of space for collaboration there in certain areas, and how does that get kind of operationalized?
I think there's a misconception that we are not currently working with OAT providers. We have lots of clients who've come from OAT providers and being referred to us from OAT providers, and we've given advice to OAT providers on the care for their clients. We do have many community connections. I just think that there are some of the louder voices in the OAT world sort of shadow that.
Yeah, I would agree with that. I think especially some of the sort of younger addictions medicine prescribers are less hung up. They're a little more ready to do whatever needs to happen. So yeah, I mean, we have some great collaborations and terrific support when we need it. I'll be honest, we don't need it much. We had tried to set up a formal connection with some addictions medicine providers, and they were like, well, what would you need us for? Like, you got it, you're doing it. So that we ended up not using it, but when we need, it's there for sure. I mean, even like I've shared clients with Vincent Lamb, so even these people that are yelling and screaming about how bad SOS is will work with us, because ultimately, like, they want to help their patients too. They just have a different view of what that would.
What that help is.
So we have to leave it there for the Q&A. I'm going to pass it back to Rebecca in just a second, but
Is what help looks like.
But before I do, I just wanted to say a huge warm thanks to all of you, all of the panelists. I know for me personally, this was really energizing and hopeful. Thanks also to Gab and everyone at the NSSCoP for your back-end support, and everyone for attending today. So I'll pass it back to you, Rebecca.
Thanks so much, Liam. Big thanks to you as well. I'm really grateful for this conversation. We need more to keep having these conversations and working through these tensions. So thank you all for starting us off, getting this conversation going. Andrea, Tracy, Mish, Emmett, thank you, Liam, for moderating, and Gab, doing your magic with translation. Thank you. And I'm so proud of our team as well. So thanks for making this all happen, everyone. And thanks to each of you for being here and listening and asking questions. I'm sorry we weren't able to get to them all. Very quickly, let me plug our website. That is where to go for more information about what we're up to, our working groups, our events that we have coming up, our past webinar recordings. You can see if you missed our panel of people who use drugs, please check that out, as well as some other great presentations that we've already had. And then if you're a prescriber, register for our prescriber consultation line that's available for members only. And we have some skills sharing workshops coming up, some public webinars coming up, and lots of other things happening. So again, best place to go for that information, our website. Okay, thanks everyone. Big thanks. Have a wonderful day. And we look forward to seeing you as we move forward. Thank you. Thanks, everyone.